So we're going to take a quick second now to discuss some foundations of research. Before we move on to step 3, where we're going to critically appraise the research that we found in step 2, we need to have a good understanding of the basics of the research process, so that way we can understand each individual article in context of the larger research picture. So the first part we're going to look at is research design, and then we'll do a quick introduction to the basics of statistics. After that, we'll move on to step 3 and see how each of these relate to the specific articles that we found in step 2 and how we can then critically appraise that research in order to move to step 4 and come up with our action plan for implementation. So our key points and objectives for this lecture: we're going to primarily spend most of our time discussing the specific research designs, and we're going to do that so we can understand what each research design is, but more importantly, so we can understand how that research design is going to affect our ability to interpret the results of that individual study. So each of these research designs have their own purpose and their own reason for being utilized, but the important part really is to remember that with each research design, the conclusions from that design have to be kept within the contents of the design. So when we talk about descriptive studies here shortly, the purpose of those is very much just to explain what is going on, whereas the purpose of evaluative studies is to figure out the associations between variables, and specifically looking to try to address some sort of causation between interventions and outcomes. And so these two different types of studies have very different focuses as far as what their purpose is, and that purpose then leads to our ability to actually make decisions according to what their results are. And so we can't use a descriptive study in order to assess causation. Also, as we go through this, we're going to be talking about each of these research designs individually, but remember that it is quite possible, and often the case probable, to have a mixed methods research design, meaning a single research article or research study is going to be using a multiple approach, so that it's going to have certain elements of the research study using one research design and another portion of the study using another design. And so although we talk about these individually, always keep in mind the fact that when we get to interpretation of our research, it's often going to be mixed methods and not specifically one versus the other. So before we get into the different categories that often are associated with research methods, we need to talk about a higher level categorization, which basically is prospective or retrospective studies. The difference being whether or not the research question was derived before or after the data was collected. In prospective studies, we come up with a research question and then set out to test that question by collecting new information. And so as such, there's more of an ability in a prospective research study to be able to collect data that will help us answer a research question more effectively. Whereas in a retrospective study, we are looking at existing data and form our research question after that data has already been created, and then try to answer our question using that previously existing data. These data sets can come from any sort of different data set that's available, whether that's your medical records or pre-participation screenings, any sort of data that's been collected already. is a great source of information to answer potential research questions. The real advantage of a retrospective research study is that you have large amounts of data at your hands. If you're collecting data on a regular basis as part of your clinical treatment in your practice, then you have all of this data that could then help you answer potential research questions, and you don't have to go out and create new data. So we're going to categorize research designs into three main categories. And really, it's going to be two categories that have to do with most of our research, and then we'll have qualitative studies and then compilation studies. And qualitative studies we'll see are going to be a specific type of research, more open-ended, trying to answer the why things happen, how things work, and do that to try to understand social phenomena or groups' thoughts, different components that are not easily quantifiable. We can't just simply measure them, so we have to ask about it in a more open-ended, freewheeling interview type style. Compilation designs are simply going to be collecting previous research and compiling them into a new research study, and you can see systematic reviews and meta-analysis are there. But the two main types of research design that you see most often in the sports medicine athletic training fields are descriptive studies and evaluative studies, and you can see each one of them listed there with their subtypes, and we'll go through each of the subtypes and describe what makes each of those subtypes. But overarching, it's important to remember that descriptive studies are specifically to describe something at a specific point in time and provide information concerning the findings. So it's going to be taking and trying to figure out what is occurring in a specific instance at a specific point in time. It's considered a lower level of evidence because there isn't the desire to try to control and manipulate the variables as much as to describe what's going on, hence the term descriptive study. These are going to be studies that the main purpose is to describe natural progressions or natural phenomena. Evaluative studies then seek to address and establish the existence of possible associations between interventions and an outcome or two different variables. And so we're trying to figure out what the causation might be and the how things work. So what causes what is the overall component, even though the reality is we're only looking at associations, but based on how we go about forming those associations may lead us to the ability to describe one as causing the other. And so as such, in order to do this evaluative studies, we have to have a certain amount of control associated with external variables, and so these are considered higher level studies. So the descriptive studies listed there: case study, case series, time series, surveys and questionnaires, and cross-sectional studies. Again, focus on this, what is occurring. So each of these have a slightly different approach, but the overarching thing that makes them a descriptive study is they're going to be describing the current situation. In a case study, the current situation is a single patient. So in a patient that is relatively unique or is undergoing a unique treatment or possibly even has a unique course of the condition would warrant the inclusion of a case study. Basically, what we're going to do is you're going to describe what occurred within that single patient. So it's very similar to your normal documentation type processes, but the purpose of this is to disseminate that information to a larger audience and create somewhat of a foundation for the possibility of larger studies. And so the real value of case studies is you can describe the unique and allow others to gain information from your specific unique findings. A case series takes that one step farther, in which case you now have a collection of individuals with either a similar diagnosis or a similar procedure over a course of time. The purpose here with the case series is the same as the case study, is to describe the natural progression of what occurred, but in a larger group. The real value for case series is you can try new treatment techniques in particular, or new evaluative techniques, in a relatively low-cost environment. It does not take a large or a lot of additional time to run a case series where individuals with a specific condition would undergo a specific testing protocol or a specific treatment protocol, and you would follow them during their normal course of treatment and thereby get information on the progression and how that intervention or testing procedure might have affected it. The important thing to understand with case series is that we cannot really have any causation inferences because there's no additional groups associated with that. So if we use the example of like ankle sprains and somebody looking to create a new treatment protocol for ankle sprains, we would have everyone in this study that suffered an ankle sprain undergo this new treatment, and then we would follow during that normal treatment or normal course of that condition and describe the final outcome. So if this was something like a new laser treatment protocol, you could go ahead and implement that laser treatment protocol with all of these individuals that fit the inclusion criteria for this case series and describe how they ended up faring. Now, the definition of case series, though, means that at minimum you have two variables, that of time and that of the intervention. And so the purpose is to get that new intervention out there and describe the possibilities of that new intervention opposed to the actual causation of it. Causation cannot be established because of this second variable as far as time. It's possible that the individuals in that example that was given for the ankle sprains would have gotten better regardless of the laser treatment just because of the passage of time. We have nothing to compare them to in this case series, and so we can't get to causation. It's simply describing in a group of subjects what occurred and thereby creating a situation where we can then go on and do higher level studies, but we will now have at least something to go off of and some reason to believe that this works, at least in a small population. The time series is fairly similar to a case series, with the major difference being is we're specifically interested in the passage of time in a time series. We are going to take a group of individuals and specifically at predetermined intervals repeat measurements in order to show the natural progression of the course of treatment or of the condition. So this is a repeated measures type design and often referred to as a single subjects design because the subjects themselves are being compared to themselves at a previous point in time. So we're moving closer now to the evaluative type studies where we're doing some comparisons, but with a lack of a general control group, we still have multiple variables, and so we're still in the descriptive portion of study design because we're specifically looking now at the passage of time and trying to describe what is occurring throughout time within our population. So the main difference between a time series and a case series is a case series describes the major events, whereas a time series describes the changes over time. And so each one has its own emphasis and is slightly different. And as you could see, there would be often a lot of overlap between a case series and a time series, as both could be done at the same time with the same group of patients. Surveys and questionnaires focus on trying to quantify quantify the information that can't be assessed in other ways. And so we're still trying to describe an overall situation. And that's what makes it a descriptive study, but we're using surveys to quantify that as far as putting it into some sort of numerical assessment compared to a qualitative assessment or a qualitative design, which is more open-ended. But the purpose here is to describe the situation by collecting information from a group of individuals, and this information could be, perceptions, it could be injury rates, it could be treatment options, anything that we're trying to figure out the occurrence of by using a questionnaire would fall into this study design. It's really important for all research designs, but particularly more so with surveys and questionnaires, that it's only as good as the reliability and the validity of the tool being used. When the entire study is the questionnaire or survey, if you do not have a good survey, obviously you cannot have quality information. The last portion of the descriptive studies design that we will be discussing is the cross-sectional design. And cross-sectional designs can be retrospective or prospective, but their purpose is to describe the overall prevalence of a condition within a population at this specific point in time. So you can either go back and evaluate all of the records trying to figure out the instance of a specific condition. So you could go through and see how many ankle sprains has occurred at your institution during a course of time and compare that to the number of athletes that you had. And that would be an example of a retrospective cross-sectional design where the goal is to see the instance of ankle sprains. Or you can do a prospective design. And the value of a prospective design is you're not relying on reported information. You can be seeking out potential cases. So this might be the case where in order to figure out ankle sprains, you would be interested in people that have sustained ankle injuries and are showing that but may not have received treatment. Now in ankle sprains, it's pretty common to receive treatment opposed to just dealing with it on a regular basis. But that's not always the case. If you take something like shoulder impingement, which somebody might have and not even really know that they would qualify for a diagnosis of shoulder impingement, you would get a much better idea of the prevalence of shoulder impingement by doing a prospective study where you would go through and test all of the individuals at your institution or within your sample population and see the prevalence of those that would qualify for having a diagnosis of shoulder impingement, irregardless of whether or not they sought treatment. But the purpose of these cross-sectional designs are exactly that, to get that cross-section of the entire population at that specific point in time to see whether or not, or see what the prevalence of a specific condition is. Evaluative studies, on the other hand, we described as trying to establish an association between different variables, or in most of the case we're looking for an association between an intervention and some sort of outcome. An intervention meaning anything that we're really manipulating. That can be a treatment intervention, a diagnostic intervention, or what have you. We're going to categorize these evaluative studies into two separate categories, observational and experimental, with the main difference being is if we looked at this somewhat as a continuum, the observational studies are moving closer to descriptive in nature, where there's not as much intervention on the part of the research team to specifically manipulate the group as there are in the experimental conditions. And so as such, we're moving in higher levels of evidence, with the experimental being higher than the observational. So the first type of observational study to discuss are cohort studies, and these can be prospective or retrospective. And a cohort study is simply a study that's using a pre-existing group as its foundation. So really, oftentimes, you're looking at the prevalence or the possibility of individuals with injuries, or looking at people that have had this condition in the past and possibly have sought different treatments. So in the prospective example there, in trying to describe that natural history, we're looking for individuals that may be at risk for a specific condition. And so we're going to prospectively test them for a number of different characteristics. So if you were looking at something like stress fractures, for example, you might take the entire cross-country team, and that's your cohort, is the cross-country team. So you're not randomly assigning people to be on the cross-country team or to do anything differently. We're just looking at the cohort of the cross-country team, and we are going to then evaluate that cohort for specific characteristics. Could be like arch type, pronation level, navicular drop, ankle range of motion, anything that you're testing from, and then you're going to follow them over a course of time and then see who develops those conditions. And as you can see in a situation like this, it's observational in nature because we're not necessarily dictating the specific treatment or the specific practice schedule of that cross-country team, but simply having those individuals that are at risk participate in their natural course, and then we're seeing what occurs. The nice thing about the prospective cohort study is you do have a decent amount of control as far as understanding what's going through and following them over time. But the biggest problem with trying to figure out risk factors using a prospective cohort study is that it takes a lot of time to test a whole bunch of individuals with only a handful probably leading to the condition. The retrospective cohort study is going through and looking at two groups that have already sustained a condition, right? And this is retrospective, so the data has already been collected, and then maybe they follow different treatment protocols or had different procedures. You can use the example of those in the past that had surgery versus those that did not have surgery. And so you're back through your records and comparing these two groups and following their course of treatment retrospectively. So you have the two groups of individuals that both sustained an injury but selected different treatment protocols. So this is not experimental because the cohorts self-selected there, and it's retrospective, meaning that it's only as good as the data that was previously collected. But it has a good advantage of the fact that you can use large amounts of data and kind of data mine those sources in order to pull out large amounts of cases and thereby get a large amount of data for individuals that have sustained a condition and then underwent a specific treatment protocol. Because it's retrospectively, you have a lot more data than you could ever get in any prospective evaluative type study. Case control studies are similar to the prospective cohort study, and the purpose is to try to figure out risk factors for illness or injury. But in a case control study, you're now taking individuals that have already sustained that condition, right? And you're now going to retest them and look for potential predisposing factors. The biggest problem with a case control study is that it's not always possible to identify what occurred first, the predisposing factor or the condition. So if we go back to our stress fracture example, if we found that those individuals with stress fractures had a lower level of ankle strength, we are not sure which came first, the lower level of ankle strength that may have caused the stress fracture, or a stress fracture causing a lower level of ankle strength. So this is an example of where we're trying to figure out the associations, but not necessarily a causation. All we know is that these are associated. The advantage, though, is that we can test these individuals for the specific things that we're looking for, compared to a retrospective cohort study where we only have the data that was measured, so it may not be commonplace to assess ankle strength for all stress fractures, so we wouldn't be able to understand if that was associated with a retrospective cohort study. But in a case control study, we can test for what we're looking for while only having to test individuals that sustain the condition. One way that the case control study can be increased in its overall methodological strength is by trying to match the injured population to a matched control non-injured population that did the same sort of component. So in our cross-country team example, opposed to testing the entire cross-country team in a prospective cohort study, if we were going to try to do a case control study, what we would do is we would take and find the individuals that sustain that stress fracture, and we would test them for the measures of interest. And then we would also test another subject that is matched based on similar characteristics, might be, gender, age, mileage, anything like that, and then test that individual as well and try to use that as our control group. Obviously not as good as if we could do it prospectively and evaluate everyone, but still better than just testing individually. The important part of these observational studies that come to play is that this is the best type of study we can legitimately do for certain characteristics. There are certain things that cannot be randomized, either for practical or ethical reasons. So we can't always use an experimental design. We can't randomly assign people to, say, sex or age or different things like that. The best we could do would be to use either one of these cohort type or case control studies designs and test the differences between these different pre-existing groups and then compare them to one another. Or we can't also randomize people to get injured, right? It would be unethical for us to look or to actually go through and rupture people's MCLs just to test and see how that creates differences in functions. And so we can't always go to the higher level of experimental components. So this is where those levels of evidence that we'll talk later about come into play, where it's important to understand the value of each different type of evidence, but at the same point in time, we need to realize the limitations that might be both within the subject design, but also within the situation and the clinical question we're trying to answer, and take all information for what it's good for, opposed to just constantly looking at the drawbacks for each type of evidence. So next we'll move on to the experimental designs, and these are the highest levels of evidence before you get into the culmination type, where it's just the combination of lower levels of evidence. And so multiples are better than singular. But by definition, experimental designs have to be prospective in nature, because we are going to be doing something after they're involved in the study, and we're going to be manipulating their situation in some way. So we have randomized and non-randomized experimental designs, and we talked a little bit about the randomization process and the value of randomization, in that by randomizing the groups, we can get a regression towards the means of the overall components of each group, thereby trying to eliminate extra variables and try to have the only difference being a singular variable of the intervention. And so the randomization is the most robust type of research design. And so people are into these are randomized into the groups and then undergo similar manipulations, and then their result or their outcomes can be compared to one another. That's what makes evaluative designs evaluative, is we're comparing results between these different groups. The non-randomization are similar to the cohort, and there's a little bit of overlap between what makes a cohort and what makes a quasi-experimental research design, with the main difference being cohort can be prospective or retrospective, whereas non-randomized experimental is always prospective, as well as for the fact that in the non-randomized, we may be doing some sort of manipulation, but the group is defined at for some other reason than the randomization, but maybe not as defined as a singular cohort. So with that non-randomized, you might have a situation where different clinics are doing different procedures, and so you're comparing one clinic to the other clinic. And obviously that has the advantage of knowing that we are doing this study, and so we can have each clinic collect similar outcomes in a similar model. We can also standardize the intervention, which makes it the quasi-experimental, because the intervention is more standardized than it would be in a possible cohort study. But the main problem with that is that definition of the fact that those two groups were decided by something other than randomization means that whatever it is as far as the other might also confound or mess up our results. And so if in this clinical example, we have two different clinics doing different procedures, we have different variables then that come into play. Hopefully we've standardized the treatment approaches so that there's minimal amounts of differences between the actual clinics as well as the different practitioners, but at the same level, there could be any sort of different reason that individuals selected one clinic over another. It could be because a certain physician refers one or their patients more to one clinic over the other, and if that physician is doing a different procedure or even doing the same procedure but is not as skilled as the other clinician that's referring them to this second clinic, then that creates another variable that becomes problematic. The problem with randomized, especially in the treatment of injured patients, is it becomes difficult to manipulate injured people's treatment of care. And this is even more so problematic in an athletic environment. Oftentimes in a true randomized controlled trial, the best course would be to compare the intervention to a true control with no intervention at all, simply based on time. But this would require randomizing individuals to receive no treatment at all for their injury. Obviously, that becomes problematic from an ethical point of view, not to mention an athletic point of view, where oftentimes the practitioners are paid to provide care and do not want to have the presumption that research is affecting their overall patient care. The way that this can be avoided, or at least minimized, is oftentimes these randomizations are the standard of care plus the intervention. So often for these randomized controlled trials, all that is occurring is they're getting randomized to whether or not they receive the intervention or not, but both groups are receiving the exact same standard of care. So if we go back to our ankle sprain example from the case series, now we have another group of individuals that have sustained their ankle, but now we randomly assign them to get the laser treatment or not, but they both receive the same standard of care. They both go through normal ankle rehabilitation programs the exact same way, and then we measure the outcomes associated with that. Compared to the case series where everybody received the intervention or the laser treatment, this now has the ability to compare between those that received the intervention and those that didn't. And if those that received the intervention perform better in outcome measures, we could assume that there was a certain amount of causation between that intervention, and then those outcome measures. Qualitative study designs, I mentioned slightly beforehand. These are open-ended interview type designs to understand social phenomena and different views of patients or patient experiences. The goal really is to understand why things are occurring and allow patients to use their own words to gain a perspective. And what the researchers are doing and what makes a qualitative study design opposed to just an interview is the researchers then attempt to triangulate these findings. And basically what triangulation means is trying to find the same information from multiple sources. This can either be from multiple individuals saying the same thing, or by categorizing and testing individuals in a multitude of ways to see if their answers coincide. So qualitative designs are more about trying to find themes to describe these phenomenon or these perceptions, opposed to quantifying the actual difference. And so there really isn't comparisons within this, but the comparison is each individual to the overall population, trying to find a theme within the population as far as their perceptions or to describe these phenomena. So to kind of start to wrap up, discuss these different study designs, not from what they're categorized, but what their kind of outcome is. So if we're trying to create a foundation for future research, basically we have a new intervention, a new special test, something new, and we're trying to figure out whether or not that has the potential to warrant a further, more robust research study. We can use case studies, case series, time series, or retrospective cohort studies really as low requirements for time as well as expense to create that foundation. So we can start applying these treatments or special tests to patients and then describe their overall outcome, or we can go back into the data and look at these individuals that may have been sustaining or doing this new treatment retrospectively and evaluate its effectiveness. If we're trying to determine the prevalence of a condition, we're looking at cross-sectional studies or surveys, with that cross-sectional study being either prospective or retrospective, where we go back into the data or go out searching for these conditions and try to figure out how many occur. You can also do that via survey by asking specific questions that have been associated with different things. Survey data for the prevalence of concussion is quite common, where individuals ask about concussion, but also then ask about concussion symptoms, and this is where they've theorized this gap between the number of diagnosed concussions and the number of actual concussions really occur in those unreported concussions. If we're looking to try to figure out associations between different conditions and injuries or different characteristics in injuries, prospective cohort studies and case control studies are the study design of most interest there, where we're either going to look at individuals that have already sustained the condition, as in the case control study, and then test them for these different characteristics, or we test them for the characteristics and then follow them for the potential of injury in the prospective cohort study. For testing interventions, we're looking at the randomized or non-randomized experimental study. These are the only true way where we can get as close as possible to then having a situation where we can test the true causation of an intervention causing a specific outcome, and that's ultimately the goal in most of these types of studies. Lastly, we have the compilation designs studies, and this is simply the systematic reviews and meta-analysis that we've talked about previously, where each one of these now has a specific design on how to do it. So that's what makes it, a specific research design, is there's methods on how to conduct each one of these. But the new data for a systematic review or meta-analysis does not come from new participants, but from previously reported literature. So systematic reviews go through their methodological process to include the specific research appropriate for their topic or research question, and then try to synthesize those findings into main outcomes. Meta-analysis do the same thing, but now pool the statistical results from each of those articles and then rerun the statistics, creating a situation where you have a much larger patient population that was tested, thereby minimizing the chance of other errors or other variables, because as you get a higher level and more individuals, we'll see next time in our statistical analysis that changes the power of the statistical analysis and thereby decreases our chances of seeing changes that are not real changes. And so both of these are considered higher levels of evidence because they are relying on previous research and combining those to form new higher level conclusions. So wrapping up, our key points: understanding that study design is required to understand and interpret the results. We cannot go beyond the design in our interpretation of those results, specifically understanding that descriptive studies do not attempt to define associations. They just describe what's going on. So any sort of causation assessment from a descriptive study is inappropriate. Also understanding that each one of these designs are classified according to specific characteristics, but each research manuscript might be using a mixed methods model. So we have to understand each one of these different types of studies individually, but also remember that each manuscript that we read or each specific part of the research process might be mixed in nature, and so we understand these in isolations but apply them in combination. Descriptive studies are studies that try to describe something in a specific point in time. Evaluative studies then try to figure out associations. And then qualitative studies try to describe social phenomena with the emphasis on meanings, experiences, and views of the participants.